Introduction and lecture will begin in 1 minute. Thanks to all the audience who follows our broadcast. We have the honor today of having Dr. Michael Levy. Dr. Levy is the Chief of Pediatric Neurosurgery at the Rades Children's Hospital in San Diego, professor in the UC San Diego School of Medicine, and the director of the Surgical Epilepsy Team and Neurotrauma Team in Children's Hospital, Los Angeles. Today, at the 2021 IWBNC, Dr. Levy is going to share his lecture, Pediatric Cerebrovascular Disease. Please typewrite your questions in the Q&A panel. We will read them after the end of Dr. Levy's intervention. Welcome, Dr. Levy, and thank you. Microphones are all yours.
Thank you. I very much appreciate the invitation to speak again this year, and I'm going to really discuss our experience with vascular malformations in children, specifically aneurysmal malformations. I'm a professor of neurosurgery at the University of California, San Diego. I'm the head of the Division of Pediatric Neurological Surgery at UCSD and at Rady Children's Hospital, and I have nothing to disclose. So the primary considerations, just given that this is a small part of pediatric neurological surgery, are numerous, but some of the most important are who should be performing these procedures. And it's a great question because more and more of us in pediatric neurosurgery are sending these cases out to the busier adult vascular neurosurgeons. And that is definitely a trend. I have always kind of opted to go the other way and take care of all of my vascular patients that are pediatric from start to finish. And I think there are certain advantages to that. Probably the most important considerations are pre and post-operative management. If you have access to a children's hospital or an adept children's facility, then you're really meeting what I believe are the standards to take care of these patients. But there needs to be a definitive expertise in pediatrics, just given the whole plethora of other type of variables they present with that can make management more difficult. There are also some questions that we still don't have answers to. What is the utility of interventional management in these kids? It's a good question. There's varying outcomes. A number of papers have been published, but I feel that we don't have a real good understanding because it's so novel that we don't have long-term follow-up. The disease processes are different in children, as I will discuss, and it's really hard to predict long-term outcome in a child, but also with the constraints of anticoagulation and other type of medical management, which are requisite in the treatment of these kids. Finally, how should we follow on ruptured aneurysms based upon location, size, and is this going to be a path that's similar to that in adults? Is it going to be different? And it's a very good question that still has to be addressed. I'm going to start with some of the acute presentations in children because it really kind of exemplifies all of the problems that one can incur when they're managing children with ruptured intracranial aneurysms. Some of the considerations in smaller kids, infants, neonates, are positioning and cranial stabilization. It can be difficult to place kids in Mayfield head frames or pin headrests in general. There are modifications to that that can incorporate kind of a head holder, a U-shaped head holder that can also help buttress the head so they won't slip. But I think the utilization of a head frame is really mandatory for the management of vascular disease. I would rather err on having punctate injuries to the calvarium or even a small depressed fracture as opposed to having somebody slip out of the pins. And so we tend to utilize the Mayfield for all of our cases. It also adds a couple of components that are really essential. The type of retractor systems we use are those that require Mayfield. And it also allows us to incorporate frameless stereotaxy into our surgical endeavors. So I really believe that it's mandatory to use some kind of pin headrest or some kind of cranial stabilization. Other concerns are pre, intra, and postoperative angiography. What kind of studies can we get based upon the appropriate dye load for these kids? How much radiation can they be exposed to? We try to be less aggressive with children than with adults, but intraoperative angiography is so vital to everything that we're doing surgically that I think we reserve a lot of the radiation load for intraoperative management of these patients. Very obvious consideration is estimated blood loss. If you're dealing with a small person, they can get into difficulty very quickly. So if you have an intraoperative rupture, that can be extraordinarily problematic. And as opposed to finding the bleeding point and establishing proximal control, like you would in an adult patient, this can be much more problematic because then you're trying to keep up with the blood volume. And it's always good to stay ahead. I think it's wise to anticipate bleeding and try your best to stay ahead. Any intervention in kids, whether it be surgical or placing a ventricular catheter, or just the mere fact that they have a ruptured aneurysm, whether it's purely a subarachnoid hemorrhage, or if there's an intracerebral component or a component that's extending into the ventricle, can be associated with hydrocephalus. Children are much more susceptible to the development of hydrocephalus than adults, and this needs to constantly be looked for. The concomitant hydrocephalus can be very difficult in the overall management of these kids, because then you're dealing with two problems. But it definitely needs to be managed, and the long-term requirements of shunting, endoscopic third ventriculostomy and such are problematic, but a necessity, given that hydrocephalus is a frequent problem with ruptured aneurysms in these age ranges. Things as simplistic as room temperature and children developing a kind of a coagulopathic presentation, given blood loss and a low temperature in the OR, are things that need to be remembered. And one of the reasons that I reaffirm the necessity of these procedures taking place into, I guess, a pediatric-friendly hospital with pediatric intensivists, pediatric nursing, OR staff that's used to taking care of pediatrics, but most importantly, pediatric anesthesia. Last consideration is vasospasm. Children do develop vasospasm, and what mechanisms do we utilize to treat vasospasm? Do we treat vasospasm as we would with an adult? Whereas protocols can differ based upon the medical center you're at. How long do you treat these kids for? Many of the same concerns we have with adults, but just a very different clinical picture. So this is a 6-month-old child who presented with an acute bleed, an intraparenchymal hemorrhage combined with a subdural component, a subarachnoid component. You see some low density here, and you see a great degree of shift already present in this patient. On the imaging studies, we see what we believe was a middle cerebral distribution aneurysm that was responsible for the bleed. This is a limited angiogram that gives some sense of the aneurysm. You can see the vessels are bowed out just from the large clot and the extensive mass effect. And basically, this patient underwent a surgical intervention. Once again, this is a 6-month-old, so 25 to 30 cc's of blood loss can be extraordinarily problematic. You have to work your way through a clot. You have to make sure the brain is soft enough to get to the aneurysm. And in this case, we were able to trap and excise the aneurysm. This is a second case of a similar type of case with a posterior cerebral distribution aneurysm with an associated clot. And then this is a child that had a bifurcation aneurysm with a posterior bleed into the ventricular system with really a minimal subarachnoid component, but mainly an interventricular component. And this is post-op where the aneurysm was successfully clipped. The child developed aggressive swelling following the clip placement in the intensive care unit, went back for a decompressive craniectomy, and additionally developed hydrocephalus, and subsequently had placement or replacement of the calvareal vault with a model. You see there's a shunt placed here, and basically here's the replaced calvareal vault, and here's the shunt in place. This is another child that presented additionally with a posterior circulation PCA distribution aneurysm associated with both an intraparenchymal component and an interventricular component. And this is post-treatment. There you can see the clip superimposed. We were unable to really adequately decompress the ventricular system of blood, something that we attempt to do, but was quite difficult given that this child's brain was quite swollen. And so we were able to irrigate out some of the intraventricular component of the blood, but really didn't have a chance to remove as much as we thought would be appropriate. This is a 7-month-old that presented with anterior distribution, probably an A2 distribution aneurysm with a large frontal clot and some displacement across the midline. And this is post-operative images. In this case, we actually excised the aneurysm with the clot. And you see here on this post-operative image that most of the A2s remain intact. This is another 17-month-old. And the difficulty with this was believed to be a left middle cerebral distribution aneurysm, but it can be extraordinarily difficult to really discern where the aneurysm is in some of these children, especially the ones with larger clots. Another difficulty is the consideration of immediately going to surgery for clot decompression based upon the stability of the child, or do we actually try to get an angiogram? My preference is to try to get an emergent angiogram because that information is essentially vital, in my opinion, but sometimes we don't have that choice. Somehow a ventricular catheter was placed into the clot in this 17-month-old, but there are many characteristics of these kids that are difficult. This child still had a remnant of the fontanelle. You can see that there's no pneumatization of the sphenoid. So there's just numerous problems you encompass with a younger child that obviously you won't see in an adult. This is postoperative imaging. You can see there was a secondary expansion, dilatation of the ventricular system into an area of injured brain. And this is a lateral film postoperatively. This is a 9-month-old that presented with a bleed, really a subdural bleed, a minimal subarachnoid component with a multilobulated kind of frontal peripheral aneurysm, if you will. And this was basically approached and excised, but once again, a very young child, wide open fontanelle. And basically you can see that the aneurysm was clip trapped and excised. This is another 14-month-old, had aggressive subarachnoid hemorrhage. These are basically just a suggestion that in younger children, how significant these surgeries can be. Children can also manifest all of the problems that you will see in adults. In this case, the child had postoperative swelling, developed a pseudomeningocele. The flap had to be removed. But all of the problems that we see in adults are also potentially manifest in a child and can be extraordinarily difficult to take care of. So looking at our series of infants and neonates, these are some of the approaches that, looking back at, I think are useful to know and understand. This was a series of 24 patients. There were 16 males and 8 females with a mean age of 12 months. The presentations are really different for the most part than you see in adults. We had one patient that presented with a subarachnoid hemorrhage, 6 had cranial nerve findings, 2 with hydrocephalus, 1 with an intracerebral hemorrhage, 1 with developmental delay, 2 presented with the Steele phenomena, 2 with just routine imaging studies. And overall, 1 was believed to be infectious in nature, 2 were presumptively traumatic, though it's difficult to determine if the trauma actually caused the aneurysm or if it resulted in an imaging study that allowed us to see it. And 21 were felt to be spontaneous in nature. Location, 5 at the ICA bifurcation, 3 were pericallosal, 6 metacerebral, 1 basilar, 3 involving pica, 4 involving P2, 1 basically involving the posterior circulation, which was diffuse, and then a diffuse bihemispheric aneurysm, which essentially took up over 80% of the skull and was not really felt to be feasible for any type of treatment, and this child was allowed to die. So 50% of our cases were basically involving anterior circulation and 37% the posterior circulation. 10 of 24 of our patients had what were construed to be giant aneurysms, representing 42%. This is a large bifurcation aneurysm that bled posteriorly into the ventricle. You can see the ventricular blood. And as I showed you before, following a clip placement, the patient had aggressive swelling, needed to have a decompressive craniectomy with then a bolt replacement with a manufactured implant and had associated hydrocephalus. This was a patient with a multilobulated aneurysm that required basically a clip reconstruction. This was a neonate with a large bifurcation type aneurysm that also underwent a clip reconstruction. And that child actually required an additional cardiac bypass during surgery. So I think the important considerations are, once again, this isn't adult disease, and that's not to say that, technically speaking, that everything that's done surgically is not very much the same in adults and children. There are just other issues that can become problematic that if you don't do a lot of kids, and it's hard for anybody to do a lot of kids, then it really can create a bad outcome. A lot of the middle cerebral distribution and even distal bifurcation type of aneurysms we see are associated with basically diseased walls. Not necessarily secondary to infection, but the wall itself is paper thin and with really manipulation at the time of surgery will bleed quite aggressively. And this is something that is extremely worrisome during your initial encounters, but something you anticipate subsequently, and usually is dealt with a shunt clip in my hands, which really seems that it's very well suited for the treatment of these cases. Interventional methodologies are difficult because you can't tell what the extent of the disease vessel is. And so if you actually do a pipeline or you bypass it using interventional techniques, is the distal aspect of your pipeline extend beyond the disease segment. We've had a case where that wasn't in fact true, and the child had a rebleed just distal to the pipeline. So the pathophysiology differs. It's really pretty obvious in the younger kids that all of these are developing in utero, or a majority are developing in utero. But also because they're congenital lesions, it also changes some of the considerations and approach. Perforators tend not to be present in some aneurysms in areas where you expect there to be perforators. These middle cerebral segment aneurysms that appear to be fusiform a lot of times can be addressed, and where you would expect the normal lenticular striate perforators to be, they're just not there. And so this allows some degrees of freedom with dealing with some of the giant aneurysms, where you can actually, whether it be by clip ligation or excision, you could remove the aneurysm from the circulation and not get a secondary infarct from also including perforators, whether it be in your clip construct or in the removal of the aneurysm itself. We've attempted bypasses in a number of children. My series, there's a total of 8 patients who were bypassed, and 50% of those remained patent. In the kids where the bypasses did not remain patent, we had no negative outcomes. So I think this is once again a reminder that there is some freedom with how aggressive you can be in children in really doing things that wouldn't make sense in the adult population, because you're dealing with a congenital lesion, a lesion that forms in utero, and something that is very, very different than something that develops over the long term as we see in adults. There's really no good nomenclature for a lot of these lesions. Dural fistula is a frequent term that's utilized, but I prefer the term aneurysmal malformations because you're dealing with a lot of giant aneurysms that are basically a dilatation with aggressive arterial input into the lesion, thin-walled venous output, but usually a single vessel going into it, a dilatation, a single vessel leaving it, and really worrisome issues with moving the aneurysm intraoperatively because it's very easy to tear that thin segment that's exiting or the venous component. But the pressure is very notable. You have large pulsatile vessels feeding some of these aneurysms. And so a lot of your management strategies have to do completely with approach, a big enough approach to allow for good visualization of everything that's important, but also limiting it just given the blood loss associated with an approach like this in a child. And once again, if you're dealing with a giant aneurysm in a child, rupture is not something that can occur because neonates and infants can die very quickly from blood loss when that occurs. So this was a case back in 1993 of a lesion. This is an intraoperative image. And then this was a three-dimensional stereolithographic model that we completed. And this essentially was our first attempt at doing this. Unlike today, this model took about 2 weeks to make. And we learned the hard way that the media had to be a powder-like media because in liquid, parts that were in different dimensions would float down to the bottom of the media. So powder was what worked for us at that time. Things have obviously gotten a lot better, and I'm going to discuss some of the three-dimensional models we're now making. So overall, in our patient population of these younger children, excuse me, we've had 5 cases that were undergoing endovascular treatment, whether it be coil and embolization alone or an embolization resection. 9 patients had basically a trapping of the aneurysm. 8 underwent a trap excision, and then 1 underwent a trap excision and bypass, which was a pica-pica bypass. And then 9 went some variant of clip ligation. 2 with clip ligation, a cardiac arrest, 2 with clipping and wrapping of the aneurysm, and then 5 standard clip ligation, as you would normally expect. And then there was the 1 patient, once again, that we did not treat based upon the size of the aneurysm and really the inability to do anything that would be of any use to the child. In these cases, 7 were modeled. And these are stereolithographic models and virtual models. And we've really found a contribution of both to really our ability to get good outcomes in these kids. So outcomes in those patients underwent clip ligation. The negative outcomes is 1 rebled and died, and that was a P2 aneurysm. 1 had a transient paresis associated with an intraoperative rupture, and this was an ICA bifurcation aneurysm that underwent a clip wrap for treatment. Of those that were trapped, 6 patients were intact. 2 were intact with baseline paresis. 1 required an M1 excision, as I was discussing earlier, and 1 remained intact at their baseline, but had a postoperative intracerebral hemorrhage following an excision at the M1, M2 segment. Of those that were treated endovascularly, 2 were intact. 2 died from rebleeds, 1 at the M1 segment, 1 was basilar, and then 1 patient had a stroke following a clip ligation, following the endovascular treatment. And then once again, the 1 patient died with no treatment. So for clip ligation, we had 11% morbidity and mortality. For trapping, no morbidity nor mortality. And in our early experience with younger children, 24% morbidity and 40% mortality for endovascular treatment. So this reaffirms that some of the giant and more difficult aneurysm trapping really is a viable way to proceed, despite the fact that that may not be true in adult populations. So if you look at 7 cases of preoperative virtual modeling, most involved M1-2 segments, A1 fistula, A1 segment, a pica segment, and vertebral artery aneurysm. And all of these patients were intact following surgery. There's no way you can correlate that these 7 patients where we had modeling really benefited from the models themselves. But what you can say is that you were much better prepared for the surgery. And I think it did make a big difference in minimizing some of your intraoperative complications. There's no doubt that it increases your anatomic recognition. I think it decreases the time until you obtain proximal control. And it also decreases your surgical duration, which is vitally important in a child. So the primary issue, once again, is blood volume. What is the estimated blood loss? What is sustainable loss? Should you transfuse at the time of incision, or should you hold off? We usually will transfuse at the time of incision with these smaller children. The importance of time cannot be overstated. Prolonged surgeries are associated with longer periods of time for children to cool down, more difficult to warm them up, chronic oozing from the bone and parenchyma, and all of these things can lead to more aggressive blood loss and potential coagulopathy. Structurally, the scalp is extremely vascular in a child. The pericranium is vascular, so when we incise the pericranium, we actually leave it intact and attached to the skull. The bone is vascular, and aggressive use of bone wax is really a necessity, and then dural lakes are not infrequent. So just getting to the pathology can be met with aggressive blood loss, and this is a significant problem. For a lot of these kids, 45 cc's is an absolute cutoff, and things can go horribly wrong if you get to that point. This was our child adolescent series of 17 complex cases. And overall, in general, the treatment and the etiologies are different, and that's the point of this slide. Locations were not that much different. The complications, 3 had vasospasm, 2 had a graft occlusion, 1 had a clip that actually slipped and required a reoperation, and 2 had infection. There were no mortalities. 5 had no change in their pre versus postoperative exams. 5 had deficits and 7 had good outcomes. So very similar outcomes as we're seeing with our infants and neonates, but a very different population. These are some of the models we're constructing now. And for every vascular case, we create models which really contribute significantly to our understanding of the pathology, but also our approach. This is a patient with a large anterior circulation-based AVM. This is a giant aneurysm in a child. This is another AVM associated with the dural malformation. This is allowing us to follow an aneurysm that's fusiform in nature. And then this is a child that had a pigtail middle cerebral segment, and this green appendage here is a developing aneurysm that we're following using stereolithographic models in addition to standard angiography. Virtual approaches are also well described at this point, and essentially you get your imaging. This is then converted into obviously your 2-dimensional model. This is converted to a 3-dimensional virtual model. And then you utilize this, whether it be through a head-mounted display, through integration with your stereotactic system, BrainLab or otherwise, and then correlating your stereotactic system with your microscope. And these are all things that we do concurrently to treat our kids with vascular malformations. And there's a number of things that are very, very positive about this. And once again, increasing your anatomic knowledge, especially for some of these more complex and abnormal malformations, really diminishes your operative time. It enhances your awareness. It establishes multiple views that you can never get surgically, and both your solid and virtual models allow for this. It allows you to rotate and interact to see behind the pathology. You can make the vessels transparent, and it really overall just improves your visualization. And I'm a big fan of these technologies because I think they make a difference. This was a large vertebral segment, giant aneurysm. I believe this child was 2 weeks old. This was a solid model that was made. They basically helped us have a good understanding of the approach to take. You can't really make a small approach and roll the dome because that can shear the venous component, which is thin-walled. So what you need is an approach that will get you directly both to the feeding vessel and the draining vessel. This is the post-operative imaging. This actually was useful in what we didn't see. This was a thrombosed MCA aneurysm, and basically reconstruction of all the salient surrounding anatomy gave us a very good understanding of what we would see during the approach and allowed for successful surgery in this child. This was an MCA bifurcation segment aneurysm. That's the three-dimensional model. And then this is basically the virtual model. And you can see basically different views, different approaches, a different understanding of angles, all of which can make these surgeries proceed much more easily. All of these three-dimensional reconstructions were really made for us by surgical theater. I don't even own the surgical theater set up at my hospital, but these were all basically donated and performed on my complex cases, and all of which really improved our outcomes. And these, as you've seen before, are just good ways to mimic your surgical approach, get a good sense of where the neck is, what the anatomy is, what's behind the anatomy, really making use of a walk around that you can't just do otherwise. You can do the same with a solid model, and I'm very fond of solid models. Almost find them to be a little bit more helpful, but that's not always the case. And this is that same case intraoperatively and allows for a smaller exposure using the Ichibon dissector. Really rapidly, we're able to identify and isolate the neck. And then with the single clip placement, able to basically cure this disease in this child. This is a 35-month-old with a thrombosed MCA aneurysm. So you can see a large, partially thrombosed aneurysm. This was the reconstruction on the imaging. And then this is the 3D reconstruction to allow us to get a good sense of how we will approach it, what we'll see during our approach, and just once again, the anatomy that's salient and a path that we're going to take to successfully treating this. This was treated with an excision and had no complications post-operatively. This was a fistula with a steel. Really doesn't fit as an aneurysm, obviously. But once again, this is arterialized high pressure blood that's leading to a steel phenomena, which was the reason that prompted us to do an excision. And this was basically a clip ligation with excision. And then this is the virtual model for this child. You can see that the vessels are no longer opacified. It allows you to see through the vessels. There are a number of things that you can do to just get a better understanding of not only the surrounding vessels, but the course of surrounding vessels, the course of perforators. All these things are really vital to getting a good understanding of what you're going to encounter. This was a 10-day-old with a giant aneurysmal malformation. And once again, I don't think dural fistula is an appropriate term for this. This is high pressure, arterialized blood feeding the lesion. The lesion's pulsatile. The vessel leaving it is either arterialized or arterialized venous structure. But these are difficult lesions. If this ruptures, there are no other options. And so preparation is the most important consideration. This is intraoperative film of the dome. This is after the lesion was trapped. We're taking out the thrombus, and then we excise the lesion. And then this is the three-dimensional modeling for this case. But it really gives you a very good sense of the circuitous course of vessels around the inferior aspect of the dome. This was actually the draining vessel. You can see the large feeding vessel. And once again, if you see the draining vessel, you can understand why rotating the lesion is not a good idea. But this really allowed for enough salient information that we could minimize our craniotomy and we could really successfully excise this with no compromise to the child, with no blood loss, and a very successful outcome. This was another aneurysm that we did a 3D reconstruction on. This was a bilobed middle cerebral distribution aneurysm. These are one of the vessels and abnormalities I was telling you where the whole segment's diseased. And the problem with this is this not only are the aneurysms problematic, but this fusiform component and the entirety of all of this is diseased. The problematic options are clip ligation is probably enough. Clip ligation with reconstruction of this wall, surgically speaking, is probably the next best choice. Interventional modalities, at least in this specific case, did not work, and this child had a distal rupture and died following the interventional procedure. This model was once again created because we were initially anticipating a surgical approach. And that surgical approach would have been a clip occlusion of the aneurysms and then a reinforcement of the fusiform segment that was distal to that. So just with regard to modeling, I think our preoperative anatomic modeling resulted in rapid isolation and ligation of proximal feeders in 1, 5, and 30-month-old infants, rapid single attempt clip placement in 1 30-month-old, verification of congenital absence of lenticular striate perforators, and trapping excision, which was successful in a 16-month-old, trapping excision with a pica-pica bypass in a 36-month-old, trapping excision in the vertebral distribution giant malformation in a 21-month-old. And once again, in these 7 cases, there were no morbidities or mortalities. But once again, taking that step and saying that A resulted in B is difficult. You can't really obviously say that, but there's no doubt that the understanding of the anatomy, the understanding of what potential approaches can be taken, and the utilization of both virtual and solid models was a significant help in all of these cases. In conclusion, managing infants and neonates with cerebrovascular disease, most notably aneurysmal type malformations, can be extraordinarily difficult. I think those people that feel comfortable with these are those that should be doing the surgeries, whether they be adult neurosurgeons or pediatric neurosurgeons. I think that having the full support of pediatric anesthesia, pediatric intensivists, and a children's hospital is extremely vital to being successful in these cases, because hopefully, as I pointed out, these children can do quite well. The integration of technology and the management of these kids is also very important, given that the dye load allowing for successful angiography, the lack of understanding of the good and bad for endovascular approaches, all of these things kind of make it more difficult for X-ray based imaging, if you will, to be the only thing you depend on. So reconstruction of whether it be 3D CT or 3D MRI scans has really made a big difference in how we manage these kids. I hope that this has been somewhat informative, given this is a strange subset of children, but it's something that people do see in their practice, that people do have some specialization in, and just technically those things that we use to approach and manage these younger children obviously can be utilized in the treatment of adults or teenagers. And I think the knowledge is helpful in dealing with any population of patient that has a complex vascular malformation. Thank you.
Thank you very much for your wonderful lecture, Dr. Levy. Thank you very much. So I'm sure all the audience has learned from your robust experience. Right now, we have a few questions from the public. So Dr. Madrignan is asking a question regarding the role of radiosurgery. And is there a role for radiosurgery in any vascular lesions in children?
Not in kids this age. So I'm thinking of kids that are basically 1 month to 36 months of age. We try to avoid as much radiation as possible, whether it be for brain tumors, trying to diminish the number of CTs we get. All children's hospitals significantly decrease the amount of radiation associated just with the standard CT. And angiography and intraoperative angiography, I think, is extraordinarily important. But in and of itself, this delivers a huge amount of radiation to a young child and a young brain. So at this point in my practice, I do not think of using radiosurgery for lesions in kids of this age. We do use radiosurgery for some vascular malformations in older children. For cavernous malformations, we're starting to do robotic laser ablations, and we've had some success with that, especially for those that are more difficult to reach surgically. But for younger population of patients, I don't use radiosurgery.
Okay, wonderful. Dr. Sanchez is writing right now. Thank you, Dr. Levy. In your experience, what should be the step-by-step training and learning curve for residents to offer safe surgery in complex cases of pediatric aneurysms?
That's a great question. I don't know that there's any easy way. You need to be fortunate enough to be at a facility where they see a large number of vascular cases, which will then trickle down, obviously, into a pediatric population. It's different, say, with true AVMs, because every adult with an AVM is a child that was missed, in my opinion. But some of the congenital aneurysms in children at some point will present themselves and be problematic. Population, being at a center that has a large catchment area, having relationships with hospitals in other countries, where you can see some of these more complex cases that will be sent to your institution. That's really been why we've been so lucky in seeing a large number of these cases. It's not anything really other than that. I think training is important. Training primarily to be a vascular neurosurgeon. If you can couple that with being a pediatric neurosurgeon, I think that's ideal. I was fortunate in that I was allowed to be a vascular neurosurgeon at our primary hospital after I graduated from my fellowship, while also being a primary pediatric neurosurgeon. So really was allowed to kind of proceed on both pathways. And so I think that's why I feel comfortable doing this, but it's all exposure, and a good vascular experience is, I think, the most essential component. Coupling a good vascular experience with a good skull-based experience I think makes you even better. And then feeling comfortable with children, whether you are or not a pediatric neurosurgeon, is the next step. But I think an extraordinarily well-trained vascular neurosurgeon, as you're going to be hearing from throughout these conferences, are all people that can do a spectacular job with these cases. It's just some of the nuances that I prefer to keep these to our own institution.
Well, thank you for your answer. Julian Andraus is asking writing, thank you, Dr. Levy, for such an amazing lecture. Due to the fact that there is not a sufficient volume of evidence that guides the management of SAH in pediatric population, which are your considerations regarding the timing and optimal neurosurgical management for this disease?
That's a great question. The easy ones are obviously those that are associated with some acute phenomena, which is a bleed. So that makes it much simpler when you have somebody that's presented with a subarachnoid hemorrhage or an intracerebral hemorrhage or a subdural hemorrhage, as we saw in that one patient. An aneurysm that is getting larger on serial imaging is also something that we will treat, depending on the etiology and if the child is syndromic, and if there's reason to believe that it's vessel disease, wall disease, we'll treat those patients. Most of the aneurysms we see, we follow because these are picked up from somebody falling off of a skateboard or having a headache or having something completely unrelated that gets an image where you see an aneurysm. We also see a lot of complex, aberrant vessel distributions. The problems we have are with kind of the circuitous vessels or the pigtailing vessels that on certain cuts will look like an aneurysm when it isn't in fact such. And that's where the 3D reconstructions are very helpful. But I agree. I think it's unfortunately a developing understanding of how to follow these kids. So I manage it much as I would an adult, which is if there's an acute event or evidence based upon etiology that this is going to get bigger, a steel phenomena, or something that really pushes you to operate. But the mere presence of an aneurysm unruptured isn't necessarily going to be the indication to operate, especially in infants and neonates where the surgical endeavor can be associated with mortality. So I have the advantage of following these kids usually for 18, 20 years. So we can get a long-term follow-up and a long-term understanding of what the aneurysm is doing and whether it's doing anything or not. But in those cases, we actually make it have to do something that necessitates surgery before we act.
Okay, perfect. Dr. Francisco Perez is asking, thank you, doctor, for your lecture. In which cases did you prefer endovascular over open surgery?
We're still learning. We had two very bad outcomes with two endovascular procedures in very young kids, and then had most recently a large cavernous pericavernous aneurysm that was treated with dual pipelines and coil placement, I believe, and the patient had a spectacular outcome. I'm willing to move in the direction of doing more endovascular work in these kids, and for glue embolizations, things like that. It's an easier decision to make. But for some of these complex lesions where you're certain that there's disease impacting the vessel wall, I'm still very, very hesitant to proceed with an endovascular route, if you will. And we have an incredible endovascular team here at UCSD with a great deal of experience with pediatrics, and basically are all learning together as to what's really the best approach. I think for the obvious things, basilar tip aneurysms, some of these other things that are well defined in the adult population, those are all treated with endovascular management. It's really kind of the complex lesions in younger kids that I don't know what the answer to that is.
Okay, doctor, wonderful. The next question is about the localization of intracranial aneurysms. Dr. Madriñan is asking, which is the most frequent location, for sacral intracranial aneurysms?
Uh, it's difficult because what we're seeing is a little bit different than what's been published. But once again, these are in extraordinarily young kids, and we're seeing a pretty even distribution between anterior circulation and posterior circulation aneurysms. In the older kids, we're heading into adolescents and teenagers, we're seeing a lot of bifurcation aneurysms and fewer aneurysms involving the posterior circulation. What we do see in the posterior circulation aneurysms in the younger kids is they tend to be giant in nature. So they tend to be more difficult to manage. We've had a couple of giant aneurysms, like the one I had showed you in the one 10-day-old child. But we're getting much more of an even distribution than I would have imagined to be many years ago. I've always been under the assumption that we're going to see more in the way of giant aneurysms, posterior circulation aneurysms. And we are seeing an increased percentage of giant aneurysms, but it's not a significant difference between posterior circulation and anterior circulation for the distribution of these.
Okay. We've got a similar question here about, well, the annual rate of bleeding. And what is the annual rate of bleeding for sacral intracranial aneurysms in children?
I don't know. And I don't think that anybody knows. We use the adult statistics. And so we kind of, that's what we have, and we try to utilize that. But the truth is we don't know because the mechanism is very different. You're dealing with a congenital aneurysm that, once again, is something that develops in utero. You're not dealing with hypertension. You're not dealing with hardened atherosclerotic vessels. You're dealing with an entirely different beast. And I'm really uncertain as to why some of these rupture as opposed to not. We'll operate on cases with a very big bleed, get in there and have a very thick-walled dome of an aneurysm that ruptured, where then we'll operate on thin-walled lesions that are getting bigger that don't rupture. I think the most worrisome cases are those, once again, where you have a diseased segment of vessel where the aneurysm is kind of like the tip of the iceberg. That's more of a warning sign that something's going on as opposed to being the primary problem. So if you just address the aneurysm in those cases, you're missing the issue, and I think those patients are going to bleed. But this is what I tell families is we really don't know for aneurysms what the chance of rebleed is. It's even hard to say what the potential for bleeding based upon size of the aneurysm is and location. And it's because you're dealing with a very, very different beast in kids. Congenital aneurysms just look and behave differently at times.
Okay. The next question was written by Dr. Torres. And this, what do you consider is the role of neurophysiological monitoring during vascular surgery in children?
We monitor everybody. The problem is in the younger kids, getting any kind of signal can be virtually impossible. Every child, no matter what age, we have in a pin headrest with or without support. All have frameless stereotaxy to assist with our navigation and approach. All have three-dimensional models made of their anatomy to assist with our approach. So I think all of these things are very important. All have intraoperative angiography. So everything we would do with an adult and beyond, we do with the child. The monitoring is something we do in everybody, but there's some kids that are just so young that we're not getting any motor or sensory signal. And so it's there, but it's not really useful.
Okay, thank you. Dr. Levy, the next question is a comparison between adult population. Dr. Peña is writing, what considerations should be taken into account when treating aneurysms in children compared to adults?
And I don't understand the question, just as opposed to adults, or?
Yeah, well, maybe what are the different elements or the different things you take into account in order to do open surgery on children compared to adults?
Pretty much the things I've been discussing. The great thing about recognition of anatomy based upon your preoperative planning is you can do something quickly. Diminishing your size of your craniotomy, just because the more bone that's exposed, the more oozing that you're going to get. Not stripping the pericranium from the bone, because that's going to create a decent amount of oozing. And the longer these kids are in surgery, there's going to be oozing that really is hard to quantify in your estimated blood loss, and that can be a huge problem. Time is so vitally important. Size of your opening is so important. You're setting yourself up for disaster by making a craniotomy that's a smaller approach, but that's where your understanding of the anatomy preoperatively and of the view of different approaches is going to give you success, because it allows for that. But keeping the room warm, paying very strict attention to blood loss, understanding that an intraoperative rupture is very likely going to be life-ending, if not associated with significant compromise. Initiating blood at the time the incision's made. Just having a pediatric intensivist that is absolutely on top of the child second by second. And it's not to say that these things aren't done with adults, but adults don't die quickly on the table. The worst thing that can happen is have a giant aneurysm in a 10-day-old rupture become associated rapidly with a swollen brain, which then makes it very, very difficult to create proximal control without hurting the patient. Just trying to do that, trying to keep up with blood, and then trying to secure an aneurysm while they're doing chest compressions. That makes these cases extraordinarily difficult. And there's only two ways these giant aneurysms can go in these young kids. They can either go perfectly or not. There's no in between. So I just think understanding that there are much more significant limitations in operating on kids. And a lot of it has to do with timing, administration of blood, and doing everything you can to avoid bleeding.
Well, there certainly is very much difficult in these complex cases. Continuing with this topic line, what strategies did you consider on previously coiled aneurysms, on the previously treated children with endovascular roots? What did you consider about that?
We've had both success and failure with coiling. Usually our vertebral aneurysms, vertebrobasilar aneurysms will coil. We've had some very good successes where coiling was a permanent cure, if you will. We've had other aneurysms that have expanded and continued to grow despite the coiling. We found out the hard way in trying to excise that segment that the coils are very difficult to remove, that the coils have memory and will open up as you open up the dome of the aneurysm, and basically delivering the coils from the aneurysm so you can trap and excise the aneurysm is extraordinarily difficult. The first one of those I did was back in 1994, 1995 with Steve Giannotta, and really took every bit of his expertise. I was just an excited observer more than anything else, but if it wasn't him, that child would have done very poorly. It's the type of thing you have to learn the hard way, I think. But if you see an aneurysm expanding despite a prior coiling, that's something you really need to understand, is that trapping with the intent of removing those coils is going to be very, very difficult, especially for posterior circulation aneurysms. We've had very good success with our basilar tip aneurysms. All of those, as should be, are coiled. And even when we see some of these start to grow and develop, despite the presence of the coils, we've now watched some kids for up to 12 years where initially it looked like the dome was getting bigger, and then that stopped. So I think for the basilar aneurysm, the success rate for endovascular treatments is extraordinarily high, and I think that's the only way it should be done. For the cavernous aneurysms, I think that my experience of two, that the pipeline has really worked quite well, whether it be one or multiple, as we did in our last kid, because the consideration of doing a significant bypass, basically a bypass originating at an end-to-side vessel when you open up Glasscock's and expose the petrous carotid, and then opening up Pernetsky's ring and basically having an end-to-side go just about at or below the level of the ophthalmic before trapping that segment. That's an extraordinarily difficult endeavor in a small child or even a large kid. And so anything I can do to get away from that approach, I think is appropriate. As I've said, I've only done 8 of those in my career, and 4 of those occluded. But those 4 occlusions did not result in compromise. So I think that endovascular treatment for the cavernous or partially cavernous aneurysms is the best way to go.
Okay, well, Dr. Levy, thank you for your answers. On behalf of CIEN and the 2021 IWBNC, I'd like to thank you once again. This has been a wonderful lecture, and we are really grateful and honored for your participation in this virtual Congress.
Thank you very much. I look forward to watching the other presenters.
Well, you are more than welcome. For all the audience, keep in mind this lecture will be available on our website starting next week. And in a few minutes, in the next room, we'll have Dr. Uwe Spetzger doing his lecture, Access Routes and Decision Algorithms for Removal of Colloid Cysts. To get the link for this upcoming conference, please follow the link pinned on the chat screen or check the program schedule on our website, cienhus.com. Thank you once again, Dr. Levy.
Thank you very much. I appreciate it.
Well, have a great day.
Okay, I'll see you soon.
Of course.